Okay, good afternoon, everyone. My name is Sabrina, and on behalf of Choice, I'd like to welcome you to today's program, Global Perspectives on Health Information Quality and Trust, which is sponsored by Springer Nature. This session is one in a series of sponsored webinars from Choice that addresses new ideas and developments of interest to the academic library community. Let's put a couple links in the chat where you can register for upcoming webinars and watch previous webinar recordings. Before we get started, I'd like to point out just a few features of the webinar software. All attendees who join the presentation are automatically muted and your cameras are off, so don't worry about generating any noise or feedback. We got that taken care of for you. In the main area of the screen, you can follow along with the presentation materials. To adjust the size of the slides or video, you can use the divider in the middle of the screen to slide the sizes to your liking. We are using the Q&A feature today. Please use it to submit any questions or comments for our speakers. We'll answer as many questions as we have time for at the end of the presentation, so please do type your questions into the Q&A module as they occur to you. You can also use the upvote feature to highlight questions you'd like or would like to be addressed. Also, there is closed captioning available for today's session. To toggle the automated captions on or off, please use the Show Captions button on the bottom panel of your screen. You can also turn on automated translation for the captions by clicking the arrow button, toggling on translation, and selecting your preferred language. Last, please note that we are recording today's program, and everyone who registered should receive a follow-up email with links to the recording and today's slides. And with that, we are ready to get started, so I will hand it over to Ben.
Thanks, Sabrina. Hello, everyone. It's a great pleasure to be here at this webinar today. I'm joining from unseasonably warm London to talk about global perspectives on health information, quality and trust. I'm chief editor of Nature Health. It's the newest journal in the Nature portfolio. I'm really giving the warm-up act for Rachel, who is going to be the main part of this talk, presenting some research published in our new journal, Nature Health. But I want to start with just explaining really why it is that a journal of public health is focusing on information and communication. And I think it's fair to say that this is really one of our priority topics that we've published a few papers on now in our first 6 months. So I'll give you some background as to uh, partly why we launched Nature Health, actually, but also why information is such a key topic for us. Well, many of the challenges facing society today affect health. This is global risks from the World Economic Forum. And if you look at the number one perceived risk in the next 2 years, right at the top is misinformation and disinformation. But actually, many of these global risks affect health. So extreme weather, armed conflict, pollution, involuntary migration. And so it became quite clear to us at the Nature portfolio that if we want to present a high quality evidence to policymakers to have real world impact, we need to have a home within the portfolio for this type of health research, population health research. Health disinformation is nothing new. This is a 175-year-old cartoon published in London by James Gilray, who was an influencer, content creator of his day. The lady in the center is receiving the smallpox vaccine, and she and the people around her who've received this vaccine are all sprouting cow heads and cow horns. And this, in a way, was a piece of Victorian health disinformation. But this reflected real concerns that people had. This wasn't an anti-science campaign. The vaccine was made in cows. It was not a particularly safe vaccine. This is an old vaccine that isn't used anymore. The word vaccine itself derives from vacca, the Latin for cow. So people had real fears and real concerns, and I think that's always important to remember. Um, This is data from this year. This is Edelman Trust Barometer Special Report on Health, which they publish annually. A few key pieces of information as a kind of background and context to what we're discussing today. Um, Overall, trust in doctors and in health systems is decreasing, and actually, trust in institutions in general is decreasing. And this is a global phenomenon with some regional differences. And Rachel will talk much more about this than I will. But just a few key pieces of information from this slide. On the left, the increasing use of AI. So if you ask people, can you do a task with AI? As well or better than a doctor. And these are medical tasks like answering general medical queries. 64% of people believe that they can do at least one task with AI as well or better than a doctor. Somewhat counterintuitively or paradoxically, along with that, people are finding it harder to make health decisions. So year on year, there is a 10-point decrease from last year to this year. That's a huge decrease from one year to another in a global survey in people's ability to find answers about health questions and make informed decisions. So you have more information with AI, but less confidence to make these health decisions. And then on the right, this relates directly to mis and disinformation. 70% of people believe at least one of six divisive health claims. And what they mean by divisive health claims is claims that the weight of scientific evidence shows are not true. So that's 70% holding at least one of these. And all of this is concerning for people working in public health. And it represents a real change in related to trust and information. We think we have a role in this debate. So, Nature was launched in 1869. We're over 150 years old. Interestingly, our first mission, published in the journal all those years ago, was actually to place before the general public the grand results of scientific work and scientific discovery, and secondly, to aid scientists themselves. And over the years, that those missions have become flipped in a way, but we are thinking increasingly, what is our role for educating the public and not just specialist researchers? This is the portfolio. We publish across, as you probably will know, from health and medicine to climate change and sustainability. And this is our newest journal, as I say, that we launched in January. We're a journal of population health. And really, it falls neatly into two halves: the causes of ill health in the 21st century. Um, this means that we end up publishing quite a lot on environmental health and climate health, but also on epidemiology. And then the other side of this is intervention. So for us, we're not a medical journal. The intervention would have to be sustainable, scalable, and affordable. And so we are publishing quite a lot on digital interventions, quite a lot on AI health, as well as things like behavioral interventions. I'm just going to give you a few seemingly disconnected snapshots of topics we're interested in, topics we've published on, to give a sense, I suppose, of where our interests lie and also some of the complexity here within the health information space. So, firstly, AI. AI is affecting everything, and the public are using AI chatbots to answer questions about any topic you could imagine, but a huge amount of these queries relate to health. And we published the first study of a general large language model chatbot, as they're known, for health queries. This is from researchers at Microsoft. So this is Copilot, and just queries that 500,000 people have used. Most of these are private companies, and so actually we have a job in trying to persuade these companies, in some cases, to actually publish so that their chatbots can be scrutinized, and so that we have a sense of how they work and where there may be potential benefits and potential harms. So a couple of nuggets here. One is that 10% of queries, health queries, relate to personal symptoms. Interestingly, one in seven queries relate to the symptoms of somebody else other than the user. So AI tools are being used for carers. Um, One of the pieces of information that got a lot of news attention was that there are more queries about personal symptoms and emotional well-being at night. So this suggests that AI tools may be filling a gap um, in terms of general medical services, but we don't know if they're completely safe and we don't know if they're completely accurate, these AI tools. Secondly, the science of how to communicate health is evolving. And it's a really vibrant discussion how health should be communicated and who should be communicated. And I'd just like to point out this comment that we published from Gabby Stern and Neha Mukherjee. Gabby was for many years director of communications at the World Health Organization, and she calls this how to communicate health in catastrophic times. And this box I really love. This is gaps, barriers, and habits that hinder impactful health communication. So, trying to give advice, essentially, the conclusion is everyone is a health communicator, and everybody who's doing any research or involved in health in any capacity needs to find a way of communicating that. Because it's only at that scale that you can get quality health information out to the people who need it. This was an editorial, not in Nature Health, but in Nature, the Mother Journal, and this was quite a provocative piece, more broadly about science, not just health, but it's worth sharing with you, I think, with this audience, because it was called "Scientists in the Future Will Not Read Articles Like This." That was the name of the article in a scientific journal, and the argument was that scientists, I think, including people in health, need to start using modern forms of communication. So the traditional peer-reviewed article has a role still, but we need to get on social media, need to be blogging, need to be giving talks. These are just two examples of initiatives we've had at Springer Nature. Here are the Springer Nature research communities, which in 2 roles ago, I've been in publishing for 15 years now. I launched these research communities, and it's community blogs for scientists. So any author with any Springer Nature journal or book can write a blog post about their work, about their life, about their research. And we think this is a tool not just for communication, but for building trust, which is a topic I'll come back to. And then bottom right, Nature is on TikTok. This is getting quite a lot of attention by the influencers, content creators on TikTok. So if you are on TikTok, I am not, but if you are on TikTok, do follow the Nature account. I mentioned trust because I think trust, and again, Rachel will talk about this, but trust, information, and communication are all entwined. This is an editorial we published at Nature Health, really in response to the Edelman survey and an event that I attended at Yale on it was called How to Rebuild Trust in Public Health. And our conclusion was, and this is actually copying what somebody had said at this Yale event, someone from Edelman, the problem for health professionals is not so much a loss of trust, but a loss of influence. So people are choosing to ignore the advice from credentialed professionals when it comes to health and listen to the advice of uncredentialed people on social media or friends and family. And this may have some positive effects as well as negative, but it's a big change. And our view is that for public health, trust and legitimacy can be converted into influence through communication, engagement, and involvement. And that researchers need to engage with their local communities, with local policymakers, with local residents, because as I started with, people often have very legitimate concerns about health, and everybody who is an expert in this area has can build that trust, build that relationship, and then be a really valued communicator. And then I'll just end with this. This is the Nature Portfolio Commissions. This is a new initiative. Um, this is a plug for the Quality Health Information for All Commission. So this has launched. It's been going nearly a couple of years now. Um, uh, the goal for these commissions is that they are evidence-led. they are interdisciplinary, and that the solutions are sustainable. So we have a commission. I'm now at Nature Health, and this is at Nature Medicine, but I'm still involved. We have a commission directly looking at this topic. We presented on this commission at a global health conference in the US early this year, and actually a librarian was in the audience who came up and said, "You must, librarians need to know about this because this is your day-to-day role." So that's actually partly um, why we're here today, because I think this is a topic that you are really knowledgeable about. So do let me know if you'd like to know more about the commission or like to be involved. And that's all from me. My email is there. I'm now handing over to Rachel for the bulk of today's talk.
Thanks, Ben. Thanks, everyone, for joining today. It's great to have so many folks attending. Very excited to share a bit about the study that we conducted, which we published in Nature Health earlier this year. I just want to acknowledge many of my co-authors who are on this presentation, both from the CUNY Graduate School of Public Health, where I am an assistant professor. Sorry for not mentioning that earlier. I also am a senior fellow at the Emergency Preparedness Research Evaluation and Practice Program at the Harvard Chan School of Public Health. And colleagues here you see listed on the slide are from CUNY as well as University of Alabama, and from other global locations as well. So this was a real collaborative effort in producing this 30-country study that represents over 31,000 respondents. Over 70% of the world's population is reflected in the sample that we conducted to really gather the first perspectives at this level on quality health information. So without further ado, we'll dive in and should have plenty of time for questions. So for those of you who sit within a communication science space or social sciences more generally, I wanted to just take a moment to ground kind of the problem that we're facing and where this sits within the sort of broader theoretical literature. As Ben just described, health information and health information quality really is a structural determinant of health. Because it shapes risk perception, it shapes care-seeking behavior, and it shapes really the responses that folks will have at a population level. I think we can't argue that communication can fix all of our policy problems, but it certainly can make it worse or better, depending on how information is shared, who it's shared by, and how that information is sort of interpreted in different cultural contexts. We also know we have what's known as by some as an infodemic. WHO is using this word, though I think it's perhaps less in vogue, but really a kind of an overwhelming spread of information in the environment right now. And that is a compilation of social media, various AI tools, legacy media, so TV and radio and clinical channels of information sharing. So that's your physician or your social workers or community health workers. And all these sources are actually kind of competing for our attention. So as Ben just mentioned, I've heard him highlight this fact before, and I think it's so critical. Folks are having a harder time making a health decision right now. And we are a little bit in an environment of information paralysis because there's so much going on and our brains can't necessarily process and cut through that. Um, in turn, what that sometimes means is that we end up listening to the same or our most familiar sources over and over again, even if they aren't necessarily experts in health content. And I think that's important for us to keep in mind. To date, we have not seen, before conducting this study, any other kind of large scale cross-national effort that had systematically sort of looked at how different geopolitical contexts really shape health information and health information evaluation. And so we set out to do that in support of this Nature Health and Nature Medicine, commission that Ben just mentioned, and really to set a baseline for what this looks like in different places. This kind of taps into a variety of different constructs that are in the communications literature space around kind of multimedia learning theory, media ecology, some of the source message channel receiver frameworks that are out there. And some of you who are familiar with different literatures may have familiarity with some of these frameworks that I'm mentioning. So I just want to share how we were thinking about it as we framed out this work. So I've sort of already started giving you this pitch, but we think this study matters not only because, health information is this structural determinant and we have this fragmented landscape, but that, we have the opportunity to really start to think about how we can communicate similarly and differently in different geopolitical spaces. And we know that information is being shared globally. Problems are global. If we think about the pandemic, or we have a World Cup right now, and we're trying to address potential disease spread in those contexts. I'm in New York City, and there were lots of active drills going on, for example, in preparation for the World Cup and bio threats. We live in a global world, and our information is global too. And we need to think about how we need to share information both similarly and differently in different places for different audiences. So in order to try and take a look at this question, we designed a cross-sectional online survey in 30 countries representing, like I said, 70% of the world's population, including 31,000 respondents over the age of 18. In each country that was included, we had approximately 1,000 respondents, besides in the United States, where we had 2,000 respondents, because we had some interest in doing some additional subsamples in different parts of the United States. And we were conducting this. CUNY is obviously based in the US, so we had a little bit of some additional research questions there. The countries that we included in this study are shown here on this slide. And I believe I also have a map I can show you, which sometimes is a little bit easier to process. When we went to analyze the study data, we stratified by age and by gender, country-specific education levels, and really, we sampled in this way to make sure we had enough folks in different buckets in order to examine analytical differences. So we needed at least 50 respondents, for example, who were in a particular age bracket and of a certain gender, to make sure we were able to not just rely on one person when we were doing our weighting. We worked with Consensus Strategies, which is a survey research firm based at Emerson College in Boston. They work with multiple international online panels, and we had in-country translation and back translation to make sure the survey instrument made sense in different contexts. This survey was ultimately fielded after much process and deliberation between August 29th and September 8th in 2025. So about a few months ago now, and it took us some time to then analyze the data, and we'll kind of jump into what we found in just a moment. Like I mentioned, I think it's easier to process this visually where we were conducting this work. So you see that each continent besides Antarctica was reflected in the survey. We had folks from different parts of Asia, Africa, South America. And like we said, we had the survey conducted in many different languages. We used in-survey country partners in order to conduct this. And so, there's certainly gaps. We didn't have respondents, for example, from the Middle East. Large swaths of Africa were not included. But there are a variety of different cultural and geographic, economic differences that were included in the study. In terms of what we asked about and how we actually started to get at this concept of quality health information, I just want to share a little bit of the details of what was in the instrument. So we included something called the Digital Health Literacy Scale. This is a scale that was developed by Norman and Skinner originally in 2006, I believe. It's a 7-item scale where folks are evaluating their own perspectives on digital health literacy, their ability to kind of find and evaluate health information online. And we then conducted confirmatory factor analysis just to ensure that this scale held across all 30 countries that were included in the study. So many of the survey instruments that were included for this digital health literacy scale, for example, has been validated before and many kind of steps had been taken to confirm its measurement properties, but it hadn't necessarily been used in all of these different geographic places. And so we did our best to ensure that the instruments were valid in as many places as possible. We also asked about health information preferences. So in addition to using this scale, which was a pre-validated instrument, we had some particular kind of one-item questions that tried to help us understand perspectives on a particular topic. So we asked folks about what qualities of information they valued, how about how easy the information is to access, where the source is coming from, and we asked folks to tell us what the most important quality of information was. We asked about which channels they primarily used to obtain health information, which formats for information they preferred, what they saw as the most believable source of information, and how likely they were to accept AI-generated health information. And you'll see on this slide, and I think it's important to just explicitly state, we mentioned this word trust, trust in AI acceptance. In the survey, we actually didn't explicitly ask folks, who do you trust for health information? Rather, we asked, what is your most believable source for information? And we did that on purpose. Trust has become this really challenging concept, and many organizations are struggling with how do we rebuild trust and what does that look like? And Ben was talking about some of this before. And because we wanted to really try and understand where folks were picking up the information that they were acting upon, we asked about believability instead. So it was a little bit of a deliberate choice on our side. And sometimes we find ourselves falling into this notion of saying, trust, but I just want to be explicit that we asked folks about believability. When we went to analyze the survey, the topics that I just mentioned, we did it across a few different constructs. So we did country level stratification, where we looked at the country country income level based on World Bank classifications. We ended up with 14 countries classified as high income, 9 classified as upper middle income, and 7 classified as lower middle income. We also used the EIU 2024 Democracy Index, which ranks kind of the characteristics of the government of a country. And we ended up with 8 countries that were considered full democracies, 11 that were considered flawed democracies, 7 that were considered hybrid regimes, which were a mix between flawed democracy and authoritarian, and 4 that were considered authoritarian regimes. And we thought about this because we thought that this political context may make a difference in terms of how folks were able to access information, and how their digital health skills may vary. In addition to the country level analytic frame, we had individual level variables. And these are variables that you often likely see in studies where there's regression models or where there's descriptive statistics. So the ages of the respondents, their sex or their education level, and their income level. In terms of our statistics that were used, and I'll get into these results very soon, but I want to just make sure you have all the information and to digest either now or when you review the slides at a later time. We use linear regression models to understand the factors associated with digital health literacy. We used weighted mixed effects logistic regression models where we had kind of binary outcomes to determine their most believable source and preferred format. And then we also corrected for multiple comparisons when all of the models that were included were weighted by population estimates. So when we're talking about these results, we're not saying, oh, these results reflect 31,000 people. We're really weighting up to that population level to make comparisons. I will also just add in the paper, and the link to the paper is going to be in the chat and made available on the registration page. We provide all of the statistics, the country level statistics by which we calculated population level weights. So you understand kind of where all of our statistical efforts are coming from. Now, let's jump in. So, digital health literacy was one of our primary outcomes. And we used, as I mentioned, that eHeals digital health literacy scale. Um, there are 30 countries reflected on this slide, which, as you can imagine, is still something we are working on trying to figure out how to present effectively. But over on that far right side, you see the global average. So that means the average score on this scale was a 27.7. And you see the bars vary. Japan and Italy there in the middle are lower or significantly lower than the global average. Um, Low and middle income countries, their average was the highest, above a 29, um, followed by, and the high income countries were the lowest. So we think that there's something already interesting to unpack here in terms of why there might be such variety in terms of digital health literacy. A few kind of comments to just pull out. For the folks who are based in the US, and it did seem like a variety of registrants were, the US scored the mean was a 28.0, which is just around the global average and above the other high income countries. And I think that what's critical and what I mentioned on the prior slide and what I want to highlight here is that, higher national wealth, being a high income country was really not predictive of having stronger digital health literacy. And this is one of the actually key takeaways that we continued to find as we analyzed our data and that we highlight in the paper. So, there's a lot to be said for trying to think about how digital health literacy is being built in lower middle income countries. When we think about perceptions of AI, this was really this single item that had to do with your respondent's likelihood of accepting AI-generated health information. The majority or greater than 50% of respondents were somewhat likely or very likely to accept AI-generated health information. This was greater than 75% of the population in China, India, Pakistan, and Indonesia, and less than 50%. Sorry, I'm not sure if that's getting cut off in some other places. So there was a really wide disparity in terms of perception of and willingness to accept AI generated health information. Again, just to contextualize in terms of the US, global acceptance, that's that somewhat likely or very likely was over 58%. The high income average was just below 50 at 48. And this was the lowest of any country level income group. The US was right around the middle, 50%. I already mentioned the highest globally here. And there's sort of this key dynamic that I just want to note, which is that US AI acceptance rising with direct experience with AI tools increase. So, we don't know how, if we did this survey right now, a year later, or not almost a year later, things could vary. So I want to kind of caveat all of these AI acceptance data points. If anything, I would imagine this has only exponentially gone up as the AI usage has continued to go up. But even last August, last September, this is what we were seeing. When we get into valued qualities of health information, we also see differences. So, these are the 5 particular items that we asked about. The information is provided by a medical provider I know. It's approved by government authorities. It's easy to understand. The source is identified, and it's easy to access. And I think what's really fascinating here is if we compare across these 5 items, the ones that seem to matter the highest are those bottom 3. So source identification, ease of understanding, and ease of access, rather than any connective tissue to medical providers or government authorities. Now, that doesn't mean that those factors don't matter, but they seem to matter less when folks were asked to rank comparatively. In terms of what Americans seem to value in health information, it was easy to understand, easy to access, and the source was clearly identified, so consistent with what you were just seeing. In terms of the US versus other global contexts, the US was following similar patterns as other high-income countries, but all 5 dimensions were actually ranked lower than the ranking levels by low and middle income country populations. Younger adults rate all quality dimensions lower than in their age group. And post-secondary education was associated with rating ease of understanding and source identification higher. So that higher education was associated with more importance in terms of ease of understanding and source identification. In terms of a call out here, just to think about, I think we are in an environment right now where we have a lot to learn about how younger people, younger adults, and folks who are aging into being adults receive and prioritize and like to access information and what's important to them in terms of the information environment. 18 to 29-year-olds were sort of the youngest age bracket in how we analyzed the data, but I can imagine that folks even younger than that may have different perspectives as well. And we need more exploration of what's going on with youth and the information environment as they age into being adults because it's so rapidly changing. These are the channels that were most frequently used for health information. And again, I'm just showing you global averages on the screen here. Social media platforms were the most ranked or most frequently used channel. They were much higher in low and middle income countries versus high income countries. You can see there on the bottom, 35% versus 15. And then the clinical channels were most used among adults over age of 60. And I think that there's a lot to consider there. Older adults tend to be more connected to a consistent medical provider. They also have a trajectory of experience, maybe seeking information from a provider or not getting answers unless they went to a provider. So this is subject to change, but is still kind of critical as we think about how information needs to be shared with aging adults. Their preferred formats for information really had to do with words and pictures. Folks were asked to prioritize videos alone, images alone, words and pictures, words alone, and overwhelmingly they said words and pictures. For everybody who is spending a lot of time making TikToks or making videos, I think that there's definitely something to be said for that, but there is potentially value in also the quick and dirty when information needs to get out fast of an image and text to go along with it. There may be more to unpack here. Perhaps if we said video and words and pictures, folks would choose that because they like everything. But I think one key takeaway for us when we took a look at this was really to think that there is still preference and use for images with words, and that this may be a more rapid way to get information out. It may be also more accessible in areas where there's data and download or Wi-Fi connectivity issues. So just to summarize some of these key quantitative findings related to digital health literacy, you see here, and if you want to just you'll have the slides, of course, or access to them, but this is a sort of snapshot of many of the things that I went over all in one spot. Some of those bars from the bottom where you are seeing the global averages, the average among low and middle income countries and high income countries, as well as the relationship with those democracy levels. And I just sort of want to highlight that for these bars, I called out some findings that we found particularly interesting, but there may be other things depending on your area of expertise or particular area of work that you find more interesting to explore, and always open to fielding questions related to that. So like I mentioned, we also conducted regression findings where we kind of explored a primary outcome of interest, what, for example, was associated with higher levels of digital health literacy. We found younger age, no surprise, was associated with higher digital health literacy, male sex, post-secondary education, and the country income. So both upper middle income countries and lower middle income countries had higher digital health literacy. So not only when we looked at it, just saying, hey, is there a relationship here? But when we actually controlled for other factors, this finding held. And again, I think that there is something to unpack there. It very well could be that there is a greater need to understand information online. because access to more traditional sources of information or consistent medical care is more challenging. But there is something to be said for this level of digital health literacy and savviness that's going on in upper middle and lower middle income countries. When we looked at kind of factors that held and were associated with most believable source, older age and female sex, there was higher odds of trusting a medical provider or believing a medical provider. The higher digital health literacy, there was more greater preference for multi-source believability. So this is that folks didn't just want to get their information from one particular source, that rather that they found information most believable when it was validated across multiple sources. And in terms of AI acceptance, there was associated with greater trust in medical providers and family or friends. So this we think is a little bit fascinating, but also plays into some of what Ben was mentioning, that folks who identify as being more likely to accept AI generated health information also were more likely to believe a medical provider as their source of information. And so perhaps there's a growing intersection there, which we know is happening, but in what ways we don't know, between AI-generated health content and medical providers. Finally, in terms of preferred formats, what did we find? Younger age groups had higher preference for video and images. Male sex had higher preferences for video alone. Folks with post-secondary education really had that stronger preference for words and pictures. And higher digital health literacy was associated with greater preference for both video and words or pictures. So there's some variation here to consider. When we look at subgroup patterns by age, sex, education, country, income, you can see, again, there's key considerations by age group. So if you are a university librarian working with younger adults, 18 to 29-year-olds, there is this higher acceptance of AI generated health information, social preference for social media information, and again, that lowest rating of all quality information dimensions that we talked about. In contrast, if you are working with older adults, depending on your setting, or the lowest level of AI acceptance, highest preference for believing a medical provider, and a preference for clinical or pharmacy channels for information, which is something that didn't come up in any other age group. Women had higher believability in medical providers and greater preference for multi-source verification, and lower AI acceptance compared to men. There were some education level differences as well. Primary and secondary only meant greater social media reliance, higher family or friend trust. And then when we went to country income, you can see down on the bottom, there were the low and middle income countries, and this is a point I've now hit on 3 times, so I won't belabor it, but had that highest digital health literacy, higher AI acceptance, social media use, and video preference, and the lowest use of health websites. And so all of this kind of plays into likely what's going on in particular country dynamics as we and are relevant depending on where you are and how you are aiming to share information. So with whom and in what place. So just a few kind of discussion points I want to highlight. I'll also mention limitations, and then I think we'll have about 15 minutes for questions. This digital health literacy paradox that is one that's critical. Social media is a dual use infrastructure, so it both broadens access to health information, but it can kind of simultaneously amplify unregulated content. And that's something for, all that we all just kind of need to be aware of and already are. There's this global dominance of words and pictures. Medical provider trust or believability does persist globally. Like they were the most believed source of information. And I think that that's critical. What a medical provider is in different places may vary, right? We didn't say, is it a community health worker? Is it a nurse? Is it a social worker, a pharmacist? So within a country, there would need to be or could be a lot more specificity in terms of what is meant by a medical provider, but they still have an important role to play in sharing quality information. And I think without stating something too obvious, one communication strategy just really cannot serve all. So there were real differences by age, sex, education, income, governance. And this kind of shapes how populations kind of evaluate and access and believe health information. And so as much as, our messages, our core messages may be global, the way they are accessed, believed, and received, it varies greatly. I want to just, acknowledge many of the limitations in what we did. There's selection bias. So there's an online panel. It underrepresents populations who do not have internet access or cannot access a digital survey in the beginning, particularly in low and middle income countries. This is cross-sectional. So nothing we say can establish causality. Everything is self-reported. So it's individuals' perception of their ability to have digital health literacy, for example. And these country level classifications, they provide, macro level contrast, but, we know that there's within country heterogeneity. In the United States, there is variety of different realities in between New York City and kind of rural counties, even within New York State. So I want to, and that's only in one very specific place. So we acknowledge that we are talking at a really high level, and there's a lot that needs to be complemented at the local levels. So just, some things that we continue to think about for health communication scholarship and practice. Digital health literacy, there's opportunities for learning from low and middle income countries. What do these programs look like? Are there even programs, especially for different population groups? We need to really match channels to context and population priorities. So social media and low and middle income countries and young adult populations, clinical channels for those 60 and older. We want to emphasize this default to words and pictures. We think that's important. And we have more to learn in terms of source and the relative importance of source for different topics. So I think that that's definitely an area for further exploration to kind of broker this or leverage, the believability of providers and the accepted use of AI for health information in particular contexts, making sure providers are part of a conversation and content that's being built out in terms of AI generated health information to try and make it more useful and make sure that quality content is what's being taken up. So that's the end of my presentation. We have about 13 minutes left for questions, and I appreciate you bearing with me and taking in on this study that we spent lots of time on. Thanks again to all the collaborators on the project, and thank you all very much for attending.
Awesome. Okay, great. Yeah, thank you so much, Ben and Rachel. Like Rachel said, we have a little over 10 minutes for questions. So if you haven't put a question in the Q&A yet, definitely do so. You can also use the upvote feature to highlight questions you like or like to be addressed. Also want to note that Ben put it in the chat and it's also in the Q&A, the link to Rachel's paper. So you can access that. It will also be in the follow-up email and on the registration page. I'm just going to launch a quick poll here that you all can fill out while we answer some questions. Okay, so let's see. The first question that came in here is a question from Philip, and this was during your presentation, Rachel. Could there be a reverse cause and effect? People who are accepting of AI from the start will use it more?
Sure. I think that it's certainly possible. As I mentioned, this is cross-sectional samples, so we have we didn't evaluate cause and effect. But yeah, I think it could certainly be self-perpetuating. And I think that one of the challenges with AI is that once you get an answer that feels good, you keep coming back to it, right? And it reinforces what we were saying at the beginning, that familiar sources become a go-to. And so I think it's critical that AI generated information is being, junk in, junk out, right? So is being kind of created and trained on the most advanced science and medical information. And I know one thing that academics, for example, are thinking about um, is how to ensure that academic studies, especially those that are typically have a paywall, for example, are actually being included in what AIs are being trained on. And I think it's the same for clinical guidance as well. It's an ongoing conversation to make sure that um, AI generated content is being uh, trained on quality content. But I think, yes, it absolutely could be that way. Ben, I don't know if you want to add.
Yeah, just there is a kind of growing body of literature on AI acceptability, and it's really interesting to follow because you can ask questions like if which you're more likely to give you confidence whether it's an AI plus a doctor, or just a doctor, just an AI. And there's often quite surprising findings related to the order the point at which the AI is consulted, what's the role um of the doctor there. And also there's some interesting research around litigation. So how likely are you to sue your medical provider if an AI was involved in that? So I think we don't know enough, frankly, about why people are using um AI tools, or what or when they're likely to trust or not trust AI tools. And also, I think there's a huge difference as to whether it's a direct to consumer AI, so you're asking the question yourself, or whether the physician is giving you a diagnosis that is in part informed by an AI. So that's not an answer, but it's just saying it's a huge area of research at the moment. Lots of unknowns.
Thank you both. Okay. Let's see, one other question, and this also came in during your presentation, Rachel, from Megan. I might have missed this, but how was the survey sent out? I think you mentioned it's an online or digital platform, but we just talk about
Yeah.
that more.
Right. So we used existing online sample frames. So folks who are part of various online panels. And then we had 10 different in-country partners. So it could have been administered in an existing app or on a mobile device. But they were all folks who were recruited as part of existing online panels.
Okay, and then let's see, a question from Anita. With respect to the text and images data, what were the images? I imagine images and health information to be infographics or similar things, but it could also mean just a stock image of a nurse giving an injection. Could you clarify this at all, or Rachel?
We don't have an answer. We didn't ask folks about a particular image. We just said, what is your preferred format for health information? And so it's at their discretion. And this is, of course, your point is super well taken. What an image looks like could be different. And so we didn't show them a particular image or say, here's a video, here's an image, which do you like better? It was a single item where folks had to say that what their preferred format for getting health information would be.
I don't know if I'm allowed to ask a follow-up question
Yes,
of
yeah.
Rachel on that, but I remember when
Yeah, my panelist prerogative, I guess.
I remember when I first. It's a really interesting question, Anita, and where I remember when I first saw this data, which was actually in a presentation as well. I think this was one of the most surprising findings in a
Yeah.
way. And it's one question in the survey. And I guess the reason I was surprised was because I've done some work in social media and blogs, and the tech companies will push you to create video content, and video
Yeah.
content tends to do better. It tends to be it's prioritized by the platform. So their algorithms tend to promote video content, and yet for health, there's this preference for words and pictures. I mean, I would love to know. more about that? Are there any plans to unpick that more, or you to
Yeah,
dive more into maybe even some qualitative research on
yeah,
that?
I think it's a great point. I think that it continues to be the most one of the more surprising findings here. And I want to also sort of acknowledge the caveats. Like maybe folks were like, oh, well, if it was just a video and there were no words, like I even now need to use closed captionings on everything, right? Because I feel like my, ears are aging. I'm like, and so I do wonder if we would find something different if we explored it further. That being said, I think a lot of folks start to watch a video and click away before it's done. And they don't necessarily get to the message because there's either an advertisement or we have really short attention spans now, right? So to
Mhm.
actually watch a full video for for health content, you have to wait till the words come out. So if you're looking for a quick hit of content, it's a lot faster to actually view an image with words. And so I think that there is potentially this differentiator between when you're looking for entertainment value on a video, like you're watching a content creator you like and you enjoy that aspect versus when you are quickly looking for health information. Um, but I think that so that's one hypothesis. I think that another thing to mention is that there is this potential difference in when you are served content and when you seek content. Meaning, if you are served information, you tend to be served videos, and that's where you kind of see information. But when you are looking for health info, you maybe find it easier if you're just quickly get that image and that text. So I think that that would be another kind of characteristic to explore in further detail.
Absolutely. Great. Yeah, we have a few minutes left. I might expand on Ben's follow-up and ask, are there any plans to redo the study? What you like to do with the data moving forward? Especially, I was
Yeah.
thinking about the like interdisciplinary possibilities, especially with um, the economic data with the digital health literacy. So,
Yeah. So as we acknowledge, this survey was conducted last year. We are still actively analyzing some of the data that isn't even included in this presentation. So, for example, we had questions related to message preferences, like message, who do you want to hear from, in what format, in sort of in what phrasing, comparing messages related to a vaccination campaign and an extreme weather related threat. Because, they're all risk communication, but they differ. And so, we're still kind of trying to explore some of the items that are in here. We would love to collaborate with any folks who are based in a particular country. We do have data now from these 30 countries, and there could be more nuances to explore. So if have an interest and would be interested in that, please reach out. Um, we did, as we prepared this paper, receive some suggestions to layer in additional external data sets, such as characteristics related to the healthcare system in a country. And for example, or other kind of economic variables. So um, that's another avenue. And then finally, just to think about repeating some of these items at a more local level would be another area of follow-up. So we are actively thinking about pursuing some analyses and thinking about additional collaborations.
excellent. Great. Okay, I think about wrapping up. We have 2 minutes left. So if anyone has any last questions, feel free to send them in. Um, and maybe just to end, Ben, you talked about this during yours, but just talk about the growing importance, and both of you can reflect on this, the growing importance of health communication and how that's been complicated by Gen AI tools and reliance on um, social media platforms.
In 2 minutes, I could give
Yes,
it,
please.
I could give it a full 5 hour seminar series on that. No, I mean it's a huge challenge, and I guess just to say it is I think the way people are, as Rachel showed, the way information of all sorts is being communicated is changing rapidly. And I think anybody who's in the business of communication needs to and information needs to needs to think really carefully around that there's this concept in comms that you need to go to where your audience is rather than where it's convenient for you to be. And I think that that's also true here. So if your target audience is on social media or is in a particular physical place, then all of us who are communicating need to make the effort to be where people are.
Hmm.
And I don't think we're very good at that actually as publishers. So it's something we need to really think about.
Okay, great. Concise. Okay. I think we're right at the hour, so I'll just say thank you so much to Ben and Rachel for taking the time to speak with us today, and thank you to our attendees for your comments and your questions. I'd like to remind our viewers that we did record today's program, so oh, excuse me, be on the lookout for a follow-up email from Choice with links to the recording, the slides, and to Rachel's paper. Also, if you have a few minutes after the presentation to fill out a brief survey, we would really appreciate it. So thanks again to all of you out there for joining us. We hope you learned something new from the webinar and hope to see you again soon on another session. Thanks, everyone.
Thank you.
Thanks.